This week on the BackTable podcast.
There are companies that are working on growing and developing human organs. They are literally growing human kidneys and livers in bioreactors with the ultimate goal that they'll be able to be transplanted into humans, with their goal of using cells from me, putting it into this liver, growing a liver so that if they're able to transplant it into me, I would never require immunosuppression. So this is very real time. This is stuff that's really, really happening. It is not science fiction. We are at a time where all of these things are just skyrocketing in frequency, in studies, and in practice.
Ladies and gentlemen, welcome to the BackTable podcast. If you're a new listener, welcome. For all of our regular listeners, welcome back and thank you for listening. Now a quick word from our sponsor. Cook Medical has been supporting physicians treating portal hypertension for decades by offering a diverse portfolio of products for transjugular access and biopsy procedures. Our Rosh Hashida transjugular liver access set and our Ring transjugular intrahepatic access set are key products relied on by physicians and developed in conjunction with physicians. Additionally, we have our liver access and biopsy access sets, labs, with a full complement of components to perform transjugular liver access and tissue biopsy. To learn more about how Cook Medical's products and our Vista training program may fit your clinical needs and preferences, reach out to your local rep today. Visit cookmedical.com or follow Cook Vascular on X and LinkedIn. And now back to the show. Our topic today is portal hypertension, and the discussion is going to be around how collaboration between interventional radiology and hepatology can improve patient care and outcomes. To help us with this discussion, we have Dr. Siobhan Flanagan, interventional radiologist from the University of Minnesota, and Dr. Tom Leventhal, GI transplant hepatologist, also from the University of Minnesota. Guys, welcome to the show.
Thank you.
Thank you. Happy to be here.
Thank you for coming. All right, so we'll start out. Siobhan, would you like to just give briefly, you don't have to go through like the training process, but kind of how your practice has evolved and kind of where you are now in your practice, and then specifically like how it kind of relates to the portal hypertensive patients you take care of?
Sure. So I did my adult IR fellowship at Northwestern. That at the time, we weren't doing a whole lot of portal hypertension work, but was exposed to the TIPS procedure there, a handful of times in my training year there, and really caught my interest very quickly during my fellowship. And I just carried that passion on through my practice. I did a little extra training out in California and then settled at the University of Minnesota for practice. And we've got a robust transplant program and a lot of folks with portal hypertension and cirrhosis in our state. And through collaboration with our hepatology folks, the practices just continue to grow throughout the years. I started out doing just garden variety TIPS placement, but quickly we recognized patient subset, visceral venous occlusion, patients who really would benefit from reopening of those veins and TIPS placement that would make them a candidate for transplant, but of course, solve their immediate bleeding and ascites issues. So over the years, that practice just has grown, and my techniques have kind of evolved over time based on my experience.
Fair. At this point of your practice, and I don't know how it works at University of Minnesota, but is a majority of your practice now devoted to portal hypertension?
The majority of it, I'd say, yeah. Probably about 60% of my energy is, 60, maybe 70% of my energy is dedicated to that.
And then you still have to do the regular things that have to be done with interventional radiology.
Absolutely.
Call. Yeah, of course.
Which, that's all part of it, and I enjoy as well, actually.
Yeah, sure. All right, Tom, so we'll go on to you. But actually, Tom, same question, but I do want to back up a little bit. Will you talk us through your training program and also like how you got interested and like how you go on to specialize in transplant hepatology?
Sure. So med school, I did one of those sub-internships in hepatology, fell absolutely in love, and so looked at the course. I realized I really liked the sickest of the sick. And so did internal medicine training and then gastroenterology and hepatology fellowship at the University of Minnesota. I went to UCSF to do an advanced in transplant hepatology year. And then the year after that, I went to Stanford to do a critical care year with my ultimate goal of taking care of really sick people admitted to the hospital with liver disease. Obviously, the sickest of the sick that we see in need of transplant and in those with major portal hypertensive complications. As evidenced by my last week when I was on call, I think I spent about 3 hours in the interventional radiology suite chatting with our colleagues to figure out really complex problems that we got really good answers for.
That's cool. So at this point in your career, like your practice, how much of it is dedicated to inpatient service and how much to outpatient service?
I do about 8 to 12 weeks of inpatient coverage. I do a little primary intensive care unit time or ICU time. I do about 8 to 10 weeks of hepatology consults. And then on the outpatient side, it's several days of hepatology and transplant clinic, and then some half days of endoscopy as well.
Okay. So the first thing that I have on the outline to cover is just like the collaborative process that you guys have established. But I do want to go back in time, maybe when the process wasn't so sophisticated. And I don't know who to ask the question to better. Like, who can remember a time when you guys didn't have the processes and procedures in place that you do now, that you can kind of talk about how it was and then take us to like how it is now?
Yeah, I would say, when my first 1 to 2 years here, so we're talking like 9 years ago, it's not that the collaboration wasn't there. It's always been a very collaborative service, but I think the hepatologists that were coming on board at the time, like Tom, Nick Lim, another one of our great hepatology partners, really predating them. It's not that there wasn't an interest in TIPS, but I think patient selection was an issue for the procedure. We've had a multidisciplinary liver conference for many years that focused, I think, primarily on tumor treatment, but those of us that had more recently trained this interest in high-level management of portal hypertension, not just medical management, but putting our two brains together to manage these patients, that would culminate in patient discussion, proper selection. Do we go with a TIPS? Do we go with a Bartow-Carto for management of their bleeding, for example? That just evolved over time, such that I would say over the last 6 years, it's been a very well-oiled machine with higher number of TIPS placements in general, because there's been that ongoing collaboration and discussion of these patients.
Okay. Well, then we'll switch it over to Tom. So now, Tom, take us through the process of maybe like give us some insight into like what that collaborative process is like. We mentioned like there's tumor board, but maybe you guys have like a portal hypertension clinic, or is there a conference where y'all go over these complex patients? Kind of take us through the process of where you're at now.
I think more so than formal conference or discussion, I think that we just have an incredible open relationship. I think part of that's facilitated by we tend to have a similar clinic space. So when I'm walking to and from clinic, there's usually 1 or 2 IR docs there that I can sit down and review some stuff with. Siobhan and I have each other on speed dial. It's those sorts of discussions of taking sort of the patient that we have, that lifestyle modifications and medical management just aren't enough anymore. And we know that there has to be an escalation, and having discussion with a group of people we trust that have had really good outcomes with really sick patients then becomes very easy. And I think it's not only been we trust them for the procedures that they can do and the outcomes that they have. My hope is that they're in a place too where they can trust us to adequately risk stratify the patients before we have them formally seen, and that we've done what we can from a medical perspective before the patient gets to that point.
Okay, that's fair. Siobhan's kind of mentioned that part of her practice is dedicated to portal hypertension, but what I want to get from both of you guys, but we can start with Tom, how many other hepatologists are there in the system like you that have maybe like a close relationship with some of the interventional radiologists that have like maybe a more focus on portal hypertension?
In our group, we have 6 transplant and 1 non-transplant hepatologist right now. I don't think that Siobhan and my relationship is unique. I think all of us feel that we have this similar relationship with interventional radiology.
Very nice. And Siobhan, how many IR docs? I mean, I know that probably everyone kind of covers the gamut, but are there anyone else in your group that's kind of focused on this area?
Yeah, there's two other providers in my practice who focus on portal hypertension management. Those three are common, just like Tom has explained, we're all available to each other 24/7, usually by phone. But the management, we try to, within our IR division at least, we have a structure to it. We have a protocol to it, from pre-procedure imaging and workup to the procedure management itself to post-procedure management. And the three of us on that team are collaborate well and practice in a very similar manner.
Okay. So you guys mentioned maybe potentially like a kind of shared clinic space. Everyone's got each other's cell phone numbers, no formal like dedicated portal hypertension discussion or anything. The patients that come through transplant, is the inbound always from hepatology, and then from hepatology it gets sent to the other stakeholders in the system like IR, surgery, or like how does that process work for maybe like a new referral to you guys, Tom?
I think probably about 90 to 95% of it is that we're sort of the gatekeepers as far as patients with portal hypertension. But what we see now is, as a quaternary referral center, whether it's coming through surgical oncology or our transplant surgeons for like non-transplant related surgery, interventional radiology for hepatocellular carcinoma management, they're seeing these patients in initial consultation and recognizing, oh, okay, this is someone with portal hypertension, cirrhosis, liver disease. They obviously need some expertise on the medical side. Then they get referred over to us.
So you guys as the gatekeepers make sure that they get plugged in to see interventional radiology whenever is appropriate. Let me ask you this. So without like going through the perfect patient or the worst patient, when do you think, or if it's a cirrhotic patient, non-HCC related, when is the right time to refer to interventional radiology? Sooner the better, or as soon as you think maybe they need a procedure?
I think a little bit more on the latter. I think that the data in liver disease has advanced so much over the last 10 years as far as medical management and some options. And so very aggressively working with people with what's the underlying causes of their liver disease, getting rid of hepatitis C, that can help portal hypertension, getting people to stop drinking and getting resources for that can decrease portal hypertension, right? And I think we've gotten better at those things. And so that helps. I think medical management, diuretics, beta blockers, things of that nature, staying on top of screening endoscopies for esophageal and gastric varices. I think we have a pretty robust and aggressive practice about those things, but then recognizing that patients progress and get sicker, and or they'll have a complication of those medications like progressive kidney dysfunction in the setting of diuretics. And I think that using that through work and publications that Siobhan and her partners have done independently and with our group, as she mentioned, Nick Lim, one of our partners, right? We've actually published data on how can we sort of push the limit on who's safe to do tips on, who's going to benefit from ascites that's refractory or hepatic hydrothorax, early tips for variceal hemorrhage. These are all things that are really guiding us towards getting interventional radiology involved.
Okay. From your perspective, Siobhan, are you guys, whenever you're getting referrals, how do the patients look as far as like when they're coming through your clinic? Are they all teed up and like there's been some discussion about a potential procedure and then you're kind of cleaning it up? Or do you treat everyone like start from square one? Let's see like what's happened with you.
From a conversational standpoint, everybody starts from square one. But I would say that I can't recall when I've had a liver patient come into clinic who hasn't been at least given some information from our hepatology clinics. What does the tips look like? What are the potential problems after you have this placed? So they're prepped with most of that information that they really care about. How likely am I to be encephalopathic afterwards, and how is that managed, et cetera. So when they come to clinic, most of the workup is done. On a rare occasion, we still need to complete an echo, cardiac echo for these patients. And most of the conversation with me is what are the technical nuts and bolts of the procedure, risks, et cetera. Most of our patients are going home same day after TIPS is placed, which I think has been a good change for practice in general and for patients. And just walking them through what your follow-up is going to look like with me. When are we doing our imaging and laboratory data? How long after placement? I think a really useful thing about seeing these patients in person, we're now we have this video capability and we don't have to see patients in person, but we've been really strict about seeing these patients in person just so we can understand what their functional status is going into the procedure. And then we get to understand what their investment is for their aftercare. If you're willing to come into the clinic visit to meet me, I feel more comfortable that you're going to follow up with what's necessary afterwards. Whereas the patient who really doesn't want to come be seen in person, it's an inconvenience, et cetera, that always gives me a little pause and a little concern. So in general, that's how things go with the clinic visit process.
What I want to know, Tom, that I think a lot of interventional radiologists don't know, or maybe a black box or somebody, is what is the initial workup for a portal hypertensive patient look like? And I know that can be like super, super broad, but if you can give us like the focused H&P segment, what labs you like to look at, why, and then like some basic imaging, like high level stuff.
No, I mean, so, right, we'll get referrals from throughout we have a pretty large catchment area here in the Twin Cities, and we'll get referrals for concerns of cirrhosis. So many of these people have already had cross-sectional imaging, CT, MRI, or ultrasound demonstrating splenomegaly, things of that. And so that's really what's prompting them to come over to our clinic, given that it is a subspecialty. We take that, we sort of parse out the history of what may have led to it. As we kind of alluded to earlier, are there potential interventions that we can provide, treating hepatitis C, treating an alcohol use disorder, that can reduce overall portal hypertension? Working with them on lifestyle modifications of things like weight loss, restricting sodium intake, avoiding alcohol, things again that we know they can do to reduce portal hypertension. As I tell people, right, that if there is a diagnosis of cirrhosis that's made, it's a scarring condition of the liver that affects the whole liver. That's such a common question. Well, how much my liver is affected? Well, it's 100%. And so we really need an objective way of risk stratifying them, and that's where the MELD score comes in. So from a transplant perspective, the MELD score has been very dynamic. And by that, I mean new labs have been added, new variables have been added because of disparities that are a result that we see in transplant. But right, the reason that the MELD score was invented was looking at risk of 90-day mortality in patients with alcohol-related liver disease who got a TIPS. In the Mayo Clinic in the University of Minnesota, Hennepin County here in Minneapolis, were all participating centers in the initial MELD study. So we have a lot of pride and belief in this as a marker of risk. So looking at things like the serum bilirubin, right, the liver's sort of overall functional status. Now we look at things like albumin and INR as a marker of impaired synthetic function of the liver, not bleeding risk. We look at serum sodium concentration as a marker of, has the hormonal milieu changed so much in the setting of portal hypertension that they're holding on to excess free water? There is sort of, from the purposes of transplant, we look at male versus female because we know that there was a discrepancy. And then we also look at kidney function because the liver and the kidneys are so intimately connected from a hormonal perspective. And putting those things together, right, we get our MELD score, and data for decades has really looked at it. And I think, I'm fortunate to practice in a place where this data came from, that Siobhan and Nick Lim have published data even most recently this year is looking at, outcomes in hepatic encephalopathy going into TIPS. And we did a study that looked at, is there a difference if you've got a MELD score of 15, which it sounds like, right, is sort of the national landscape for consideration for TIPS. But we felt very comfortable in pushing that score up to 20 with comparable, if not same outcomes. And so it's like knowing that data and looking at that, we're like, okay, this is important stuff. I think the outlying thing is, right, knowing and understanding potential complications of TIPS, right? The potential for worsening encephalopathy, having those discussions with patients, making sure they're aware of the signs and symptoms and have medications, but also, right, it's the increased right-sided preload. So we need to do our due diligence to make sure we've got an up-to-date echocardiogram that's not demonstrating right heart dysfunction, so that we're not setting up our patients for failure.
Where does biopsy play a role in as far as the patients that come through and there's imaging and lab criteria that's meeting the diagnosis of cirrhosis? How does that fit into the overall picture of where patients stand either on the transplant line or in how they get moved on to other services?
I mean, awesome question. We know kind of globally that by the time that someone develops cirrhosis with significant portal hypertension, if we get a biopsy, the likelihood that we actually see the cause or etiology of the liver disease is pretty low, right? We're going to see a lot of fibrosis and that's about it. But I mean, even this past week when I was on service, someone was having peristomal variceal bleeding and didn't have a great history for any particular reason for why they would have developed cirrhosis. And that was going into the interventional radiology workroom, sitting down with a couple of the staff, reviewing the imaging, and me saying to them, I don't feel that I feel comfortable with the diagnosis of cirrhosis yet. I want to move forward with a transjugular liver biopsy with portal pressure measurements to say, hey, we get the objective information of the biopsy, potential etiology, but we also get an objective measurement of portal hypertension to help us say, okay, we believe then that this is the cause of the bleed.
Siobhan, real quick, I'm just curious of whatever you're doing your transjugs, how do you take your portal pressures?
This is a hot topic of conversation. It has been for a few years now.
And this is not the transjug podcast, but we could go back to it. But it's hard to talk about transjug without asking another IR doc how they do it.
Yeah, absolutely. We've found with our hepatology colleagues that that old method of taking that wedge hepatic vein pressure and just moving your catheter back to the right atrium is actually not reflective on the actual, what's the degree of portal hypertension. So, when we're seeing our patients for the first time, we know that really the most accurate way to determine the gradient is getting that good wedge pressure, and you want an IVC pressure. But we take it one step further. We're actually looking at hepatic venous outflow obstruction as well. So we're measuring, the wedge, the free, a few other points along that hepatic vein, including the central hepatic vein, IVC, and who doesn't always get a right atrial pressure, but that IVC pressure is important in the calculation.
Okay, good. All right, so before we dive into the tips part of it, though, what are some of the things or some of the procedures that you consider the offering from interventional radiology, like the full gamut of procedures, like from all the way from paras to tips that you see in your portal hypertension practice? Just
from diagnosis, there's the liver biopsy, transjugular liver biopsy with portal pressures. It runs the gamut from fluid drainages, paracentesis, thoracentesis. I'm really interested in the whole physiology behind ascites, and if fluid's looking suspicious, you have to have it on your radar to check for chylous ascites potentially in patients. From other diagnostic workup, we're offering the transjugular liver biopsy with those pressures to estimate the portal hypertension. And then from pure management of the portal hypertension itself and appropriate candidates, we're, of course, offering tips for those patients with isolated gastric variceal bleeding who are, encephalopathic or their liver function can't tolerate it. Tips we're offering, we primarily do CARTO here. And then, Tom brought up this interesting case of, every once in a while we're dealing with a patient with peristomal varices, and if they truly have portal hypertension, tips is what they need. But on occasion, that's not possible. And you're just looking at doing localized therapy for those peristomal varices, whether it be, sclero, coiling.
So pretty much the full gamut. What about, is there a role for Denver shunts ever in this patient population, or is it something?
That really has, that exit our practice pretty quickly,
Okay.
Just from an outcome standpoint,
okay.
Patients didn't do well with it.
Okay.
And, I think for us, we're a big transplant center. I think we see far more patients that may be destined for transplantation than are palliative.
Okay. Fair statement. Tom, if you could, will you talk about either a patient that may come through your clinic or the transplant clinic and that gets referred over for tips, like a couple different scenarios that you're like, all right, we should get this patient over to interventional radiology for potential tips workup. What kind of patients end up getting shifted over to IR for potential tips?
Are you more interested in, say, outpatient or inpatient?
I'll start out with outpatient, the outpatient considerations.
Sure. I think the predominant reason that we're making referrals for tips is diuretic refractory ascites or hepatic hydrothorax. I think that, like I said, we're aggressive. I think that with case management for helping to manage these patients, requesting that they're getting frequent labs, but we know that the natural history of cirrhosis is they'll progress, and they'll ultimately progress to where they develop a kidney dysfunction, be it type, hepatorenal syndrome, or, sort of a consequence or side effect of their diuretics. And that I think that once we get to that point, sort of regardless of MELD, if less than 20, we're pretty quick about saying, hey, we've tried this, you're getting your paracentesis. The number of patients that I have in clinic that are getting them weekly, twice weekly. I've had some patients that needed them 3 times weekly. And you can only do so much, and we recognize that with patients, is that you can recommend these lifestyle modifications of sodium avoidance, but it is what it is. They're human. And so I think that it's the refractory ascites or hepatic hydrothorax that really is the big push for us to get these patients into TIPS. And, I'll toot Siobhan's horn for her. We do the second most TIPS in the United States. And at least that's the urban legend that's going around. And I believe it because we're very assertive about referring them and our outcomes, and the resolution of ascites or hepatic hydrothorax is very impressive. And along with that, the improvement in quality of life, the ability for your patient to be more active, ultimately, I think prolongs life till time to transplant, or else just prolongs life. And so it makes a really big difference.
All right, Siobhan. So from your perspective, I guess what I want to know, like one of the questions I have in my head is, I can remember being in training, I guess I came out in 2015, and the number of TIPS that we did at the very first half of the year was like 10. And the second half of the year, it was like 100. And like there was like this quick ramp up, and then like I was at Georgetown Transplant Center, and then it just never went down. Like it was like, up and to the right, and then kind of leveled off. Do you remember that point in your practice when your TIPS placement went kind of up? Like, was there an upward trajectory, or was it kind of a slow burn up?
I think it was a quick change for us, and I think it was twofold. Our newer hepatologists really looking to manage their patients' fluid, and that really changed the practice for us. But then also, when Northwestern's data came out on, making patients transplant candidates, that really changed things for us as well. And I think since then, it's just been a steady rise for us in general. I don't think as much as that, 2016 or so, we were a little bit behind you guys. 2016 to early 2017, I really remember that time as being a transition point for us, doing more and more TIPS.
Tom, would you echo that sentiment that it was some of the data that came out around that time, and maybe different hepatologists coming on board and were more interested in getting a little bit more aggressive with fluid management?
I would. The early study that looked at sort of like early TIPS for, we'll say, even variceal hemorrhage, right, came out 2010. And then it was like every couple of years, another big study looking at, inpatient mortality was reduced, things like that. And it was like, okay, we know that there's certainly indications where it makes a dramatic difference. But I think then that got broadly applied to say, hey, like we can make a really big difference. And understanding that there are people with portal hypertension that don't have high MELDs, but still have significant ascites and significant hepatic hydrothorax. So we couldn't always weigh on transplant as being the ultimate. It was the ultimate, but it wasn't necessarily going to be feasible anytime soon if they didn't have access to, say, a living donor. And then this was just hey, this is something that works, that can prolong life and reduce morbidity without transplant. And I think that's why we saw this ramp up.
So one of the things that often gets discussed or has been discussed is like the big push and pull between the benefits of TIPS versus the downsides. And Tom, in your mind, what would you say are the top 3 downsides to a TIPS procedure that in your mind, you're like, this is kind of like the worst situation that can happen post-TIPS?
I mean, before you threw in that last sentence, I would have said none. I think they're phenomenal.
Okay.
I just, again, it's just our practice. I just are in so many ways life-changing, right? What we worry about is refractory encephalopathy that leads to an almost comatose state. I mean, I've been practicing hepatology 8 years. In that time, we talk about this, right? Because it's so rare. I can think of 2 patients who we actually had to close down the TIPS because of such dense refractory encephalopathy. And I've ordered a lot of tips, and my partners that have been here as long or longer than I have comparable results. I've seen very few people go into like heart failure, right-sided heart failure, because of the increase in preload. But I think that's why, just to uniform our practices, we've got to get an up-to-date echo. We have to make sure that we're at least looking for that risk stratification. Outside of that, I don't even know if I could come up with a third risk that I would really worry about, just because of how positive the outcomes overall are.
All right. Siobhan, all right, so kick it over to you, and I'll kind of just open it up. If you want to just kind of talk about, like, walk us through what your TIPS procedure looks like, your most modern version of your TIPS, whether you use, all the things you use or do not use, and kind of why.
Yeah, absolutely. So, my go-to TIPS set is the Roche Ashita. I'm just incredibly comfortable with that thing. Over time, the more recanalization work that we do, BD has its Liberty set, which is nice for recanalization patients. If you just have a really, short A to P distance, but a long, anterior throw, that device has changed the game for those rare, difficult cases. But by and large, the Roche Ashita is my, my go-to kit. As far as, the procedure itself, I won't bore everybody with the technical, access.
It's no bore.
Okay.
Yeah. But go ahead.
Classic steps that everybody goes through, your hepatic vein catheterization and just ensuring that you're where you think you are. And, most of my tips are right to right. The use of ice for us has increased over time. It's not in every case for me, but in Minnesota, we have a different body habitus than maybe California. And ice really can come in handy, especially when patients have had a portal occlusion or maybe a very small portal vein that's just, tough to get to. Ice has really changed the games for us in those very difficult cases. I don't necessarily do the CO2 venogram. I learned contrast wedge venogram. As long as you've got careful technique, that outlines the anatomy really well for me. But, I would say I'm relying more on the ultrasound these days than going AP to RAO to send my needle across from my hepatic vein to my portal vein. I think ultrasound, for those who don't use it, get used to using it. It's a great device, and it really can get you out of some tricky situations, and it just provides a lot of confidence and quickens your procedure. It certainly has for me.
Hold on, when you mean ultrasound, are you talking about the transabdominal or
ice? No, ice.
Okay.
Yeah,
Gotcha,
sorry,
gotcha.
ice. Transabdominal has its role too. I like intracardiac echo, especially for those large obese patients who have pretty small portal target, or we've had to recanalize it. And then from there, it's just my pre-pressures, marking catheter, and then placement of the Viator. Pretty garden variety for me. Our recanalization procedures, it all depends on the configuration of the occlusion, what approach we take to reopen it. I like the transplantic approach quite a bit. On occasion, these aren't cirrhotic patients, so I'll save a lot of the chatter about this. But on occasion, you need unusual mini laparotomy approach to get SMV access, maybe. But by and large, we accomplish our recanalizations with transplantic and maybe adding a transhepatic approach if you just can't quite connect the dots to reopen the vessel to progress onto TIPS. And then completion pressures, we all know that the hepatic venous end is usually the end that we have not quite long enough. It's a little short, and that can lead to early reocclusion. I'm usually doing a venogram at the end through my sheath, right at that hepatic venous end of the TIPS, to make sure, I'm flush up against or very close to that IVC confluence. Pressures get done, and then we wrap it up for the day.
So as far as endpoints, what do you use for your pressure measurement goals to say, like, okay, this is done, as far as your dilations afterwards, or like any tuning up?
It's a great question. And I think it's, for me, it's less than 12. If I get it to less than 12, I know I should really help the patient with bleeding and ascites. And, initially my dilation is to 8 millimeters. If I, especially for patients who may be at higher risk for encephalopathy, maybe they have some pre-procedure encephalopathy that wasn't just West Haven grade 1. It was more So if the 8 dilation to 8 gets me to that gradient, then I'm done. If I need to dilate from there to achieve that gradient of less than 12, I go to 10. But always in the context of each patient and their risk for encephalopathy.
Gotcha. As far as what happens to the patients post, you said a lot of your patients now are going home same day.
They're going home same day.
Is that relatively new for you guys?
We've been doing this for about 18 months now. Our protocol for this is the patient will stay up in the PACU. We recover them for about 4 hours. Some patients who are maybe a little borderline, you're a little more concerned about them, you watch them for 6. But, as long as they're doing well after the procedure, they're going home after that observation time.
So they go home same day, and then Siobhan, I want to know when they follow up with IR, and then also, Tom, I would like to know what they look like as you guys are starting to pick them up post tips. But Siobhan, we'll start with you.
Yeah, in IR, I see them at 1 month post procedure, but we've got a great nurse clinician support team in IR, and they're calling the patient, day after. We have a day 1 and a day 3 call just to make sure that doesn't sound like they're having issues with encephalopathy early on that maybe they aren't even recognizing. Part of our, setup for our patients when we're meeting them in clinic is to understand what's your social and in-house support at home. Knowing that they've got someone else in the household with them is a more comforting thing than thinking about them being on their own. So there's someone to really watch out for any development of encephalopathy as well.
Cool. Do you send them home with any meds for potential encephalopathy treatment? Do they have that going home? Or so I've heard some IR docs will get them these prescriptions even before the tips goes in, or I didn't know if you guys had anything like that in place.
Yeah, and I know Tom can talk to the hepatology side of that's a desirable thing on our end to have the patient ready with those medications.
Yeah, so Tom, what does it look like from your end?
We made the assessment, they go in for it. And I have to say, it's not that you're selling it, right? It's that you're doing the right thing medically. But when you have these discussions with patients in hepatology clinic, how long am I in the hospital after the surgery? And to be able to say, no, it's a procedure, it's a day procedure, you'll probably go home the same day. It takes away a lot of reticence that they may have to go through with it, which is huge. My guess is that the majority of patients that we're referring for tips are already on treatment medications for hepatic encephalopathy with either lactulose or rifaximin. So many of them already are. I certainly have had Siobhan or her colleagues reach out afterwards, at that 1 month follow-up visit where they're starting to hear to their nurse coordinators and stuff, maybe there are some changes that may signify it. Not uncommon, right, that they're practicing the medicine and getting those medicines on board, or else our team will take over and manage it. I feel like it's very rare that we're actually seeing a clinically significant worsening of encephalopathy after the procedure.
Cool. Very nice. As far as after they have their tips, when do they get plugged back into your clinic? Does necessarily having a tips mean that, you need to go back and see transplant clinic, 2 weeks after, 1 month after, or do they still just stay on their regular schedule of what they normally go?
They'll stay on their regular schedule. And I think a lot of that has to do with the trust. And I think the aggressive medical management on the IR side, seeing these patients in follow-up, I don't think happens everywhere. It might, but in my experience, it hasn't. And so we feel that they are getting comprehensive care and that we know if issues come up, especially in the setting of the pandemic, virtual visits, access to the EMR, you're much more likely to get alerts from your patients of things are a little bit off. So because they had this interventional procedure, even with the known risks, it doesn't escalate our need to get them back in.
That's great. So what has the IR team done right as far as their clinic presence to make you guys feel more comfortable with, once you send them for the procedure, that you understand that all that will be taken care of? I just imagine, Siobhan, maybe you guys have been very sophisticated for a long time, but I was just curious as maybe have they've been more sophisticated in their clinic presence that's endeared them or made them more or instilled more confidence on the other side of things.
Sure. I came back to the University of Minnesota in 2019. And very early on after ordering one of these, I was getting inbox alerts and messages from Interventional Radiology of, hey, they had their tips. I got their ultrasound 1 month post, saw them in clinic. Seems like they're having lower extremity edema. You okay with ordering diuretics? And it completely caught me off guard that this was even a practice that was in place, that other people were managing this stuff. I just always assumed, right, that I'd be getting the call. And so very quickly in coming back that it was beyond procedural from my perspective. It was true medical management and recognition of this stuff. And then, hey, would you mind ordering the diuretics? Absolutely. That's my job. You guys don't have to worry about that, but having someone lay eyes on someone and know that and passing that along just made it so much easier, and I think led to way better outcomes.
That's great. Siobhan, from your perspective, so also want to know what you think is, as you've seen the practice progress and evolve, what you guys have done right, but I also want to put you on the hot seat. Can you think of any missteps that y'all have had along the way that y'all have used for improvement? You know what I mean? Like lessons learned.
I'm going to have to think about that for a minute.
Okay.
Not that we make plenty of mistakes.
Zero mistakes, zero mistakes.
You know what I mean? Yeah, no, not zero mistakes. I got to think about that for a minute.
What are the things that you think of as you've seen kind of the clinic progress or y'all's clinical presence progress, that y'all have done right to, I guess, have a more, I'm always trying to push the idea that having a procedural presence is a better thing for interventional radiology. You get better outcomes, you get better referrals, you have better relationship with your colleagues. And I was just curious if y'all's practice, if you've seen that evolve and see that relationship build because of how clinical y'all's practice has become.
Yeah, I've seen a distinct change in our service and our relationships with more than just hepatology. Our relationship with hepatology has been the model to do this with other procedures, partner with other clinicians. I would say predating 2015, there was a tumor conference, but outside of tumor conference, not nearly as much conversation and collaboration as there is today. I know that, overall patient outcomes, they've always been good, but they've improved from regards to how quickly patients are managed with, maybe like Tom was mentioning, or you were mentioning, peripheral edema after their TIPS is placed. Maybe in the past, it was something that patients struggled with for, 2 or 3 months. But, we're talking to them early, seeing them up front, recognizing that this is happening and getting them the medical management they need sooner. So from that standpoint, we're leaps and bounds beyond where we were before. And, our whole field is wanting to progress to this more clinical practice. And this has just been a good example of how that's successful and improves patient outcomes just from the ultimate outcome of success. You've managed their portal hypertension, but just those intricacies afterwards from a symptom management standpoint.
And to kind of go the other end of the spectrum, and I think how important the relationship is, I've gotten a call from one of our IR partners to come to the IR suite and someone that was scheduled for a TIPS that day as an elective outpatient procedure. And they'd gotten labs that morning. They had done their assessment, and they had significant concerns about, was this someone where this procedure was going to be safe on this day? And in going there, taking a look at the labs, taking a look at the patient, and, having had that longitudinal relationship saying, hey, there has been a significant clinical decline. This would not be safe right now. I don't know. Again, don't know if that happens everywhere, but it made a big difference and probably prevented a really bad outcome.
Well, and I would say, kind of missteps on our end probably is in line with the previous conversation. The times when before the close follow-up and collaboration, patients just not doing well with post-procedure symptoms. I would say that in the past was our biggest misstep, really the clinical management side, not the procedural management side. But even that close collaboration has resulted in us not placing TIPS in patients who maybe on the day of, like Tom mentioned, aren't appropriate to have it done. And I think, in the past, we had one case where, the updating our echo, we're pretty stringent about, it'd be great to have it in the last 6 months because things change over time. And, one misstep I recall on our part was not having an updated echo. And this was probably maybe 7 years ago, not having an updated echo on a patient who went into right heart failure after their TIPS.
How many days a week or days a month do you spend in clinic?
I have 4 clinic days per month.
Okay, so you do 1 a week basically,
Yep.
And then procedural the rest of the time.
Correct.
So I want to talk about the future a little bit, and sometimes the questions are tricky, but I want to leave it as open as possible. As far as the portal hypertensive practice, is there anything any research that you feel like either as part of your group or you guys are collaborating with? Is there anything that you're excited about that's on the horizon for portal hypertension and how you guys are managing it?
Tom has mentioned this before, we're really looking forward to what the Alta Tips data is going to show us. I think we're going to do a much better job as a field when we have that type of data. And, in interventional radiology, we all struggle with what's the quality of our data and the completeness of our data. And this is one of those things that I think would change how we manage these patients or help us just identify what are our missteps, what are our potential areas for improvement. I would say that. And then the other thing that I really look forward to, and I think our conversation honestly has touched upon it, that, I think there's a role for portal hypertension management, almost service line in any hospital system. That's a catch for patients with cirrhosis, but it's actually a catch for patients who, maybe have a visceral occlusion and need that taken care of. I think there's a lot of opportunity there. And once you create a service line for these types of things, we come from a big, it's a big health system here, but that gives opportunity to standardize things out for the community sites, even raises awareness, creates understanding. So I would say those are the things I'm really looking forward to.
Nice. Tom, same question for you, but I'll even open it up even broader. Like maybe it's not portal hypertension related. Maybe it's just in the transplant realm, anything that you're excited about from y'all's data or anything maybe that, when I say y'all's data, the hepatology data or anything that maybe University of Minnesota is putting out?
Yeah, I know that, right, Siobhan and Nick, our partner, has really looked at, what does encephalopathy really impact your outcome and tips? And just publication this year really saying, no, probably not. And I think that Alta Tips, where we are actively participating, enrolling patients on a near weekly basis, I think it's really going to give a lot of really good objective data to the hepatology and IR community to say, look, these are the median MELD scores of people coming in. Look at the outcomes that they're having. Maybe we can push the envelope more globally for patients with portal hypertension. I think I get a little bit interesting perspective is that, right, in the GI and advanced endoscopy world, there's a lot of advancements as far as treatment of complications of portal hypertension, not only like EUS-guided liver biopsies with portal hypertension management, but EUS-guided gluing and coiling of varices. I think we're in a very different position or unique position, particularly with our relationship with interventional radiology. I think the benefit that we have is my job as a hepatologist is to truly understand portal hypertension. And then that allows us to really say, well, where could the endoscopic approach be really valuable? Say in someone who has a really high MELD score, who's having refractory bleeding, that could be a really good indication for GI to go in and do these procedures. But also understanding that what they do isn't treating portal hypertension. It's treating a complication of it, and truly interventional radiology through TIPS and or transplant is ultimately what's going to treat it for our patients and prevent this stuff long-term from happening again.
Well put. Anything that I didn't bring up that I should have brought up that you thought was worth talking about? Siobhan, start with you.
Yeah, I think always an interesting conversation within interventional radiology is this concept of early tips. How soon do we do it afterwards? And, I think the inpatient conundrum is, what are the resources to get an inpatient tips done? Ideally, we would do it in 72 hours after an acute variceal bleed. Do we have the resources to get that done? Is there anesthesia availability? Is there interventional radiology availability to get that done? And I think that, I'd love for us to continue to look at that. Do we stick with that? Is that 72-hour goal really ring true for us? And if it does, how do we get there?
Mm-hmm. How's the anesthesia at y'all's place? Easy to come by, tough to come by, depends on the day?
Really tough to come by. And it does depend on the day. And listen, they are a busy crew. And what's really a challenge for them, I think, is that everything gets anesthesia now. And I think that's just a tough thing for them. The demand has gone up exponentially, and their presence hasn't. They don't grow on trees. It's hard to get them, especially for a big medical center like this with really complex sick patients. It can be hard to build an optimum crew. So they do a great job for us with what they have.
Tom, same question. Anything that I didn't bring up that seems like a glaring hole in the outline of the show?
As far as like the guys of the show, it's really interesting, admittedly trying to figure out like what you guys are trying to do in this podcast and stuff. I started listening, and Siobhan and I were talking about it before we got on this sort of most recent episode and talked about moral injury, right? And as proceduralists, I do procedures. I do procedures on people with active variceal hemorrhage and stuff. And you understand it's a really sick population with a very real chance of dying because of a complication of their problem. And so I think it goes beyond even the trust of, can the technician, the interventional radiologist who's doing the procedure, right, do the procedure to the utmost of their ability with adequate risk stratification. But it's like Siobhan was talking about with this idea of early tips. We have people come in with MELDs greater than 20 that are having active variceal hemorrhage that we can't treat because maybe they've been banded 4 times and everything's scarred down and we can't get endoscopic intervention on it. It's that real discussion and trust of, this is someone who's going to die of a complication of their portal hypertension. Let's have a discussion about risks and benefits that as a group we are willing to accept, because I would never want my interventional radiologists to feel like it's in any way their fault. It's like the idea of transplant. I don't make a decision if someone's a transplant candidate. Our transplant group does. This is how do we have an open discussion, understanding risks on both sides are very real. What do we feel we can accept? What do we feel is safe that we don't feel that we're putting ourselves at this risk of very severe moral injury? And I think that's an important thing to factor in, especially in modern medicine.
Tom, do you feel like you have a better grip on that than, I don't know if you have any hepatology colleagues or GI, GI so procedure-oriented, or a lot of GI docs are. Sometimes I feel like that's a little bit missed in other referring docs to interventional who don't do procedures or are more clinically focused, that it's almost like if you can do a procedure, you should do it. But it's whenever I'm talking to other proceduralists, I feel like they understand like kind of the weight of that discussion of risk versus benefits. Like, is it a procedure that's going to have a net positive? I just feel like you're very in tune with that, Tom.
I think as a transplant hepatologist, you have to be, right? On the transplant side of things. Well, if there were an organ for everyone, it becomes less of an issue. But it's really, when we go through these discussions, is this for all the reasons the right thing to do, the safe thing to do, that we could expect an appreciable outcome for? That translates back to the clinic work I do, the endoscopy work I do, the referrals that I'll place to other proceduralists. And so I think that in transplant hepatology, we really do think about it kind of guiding a lot of our decision-making, particularly when saying like, okay, if you've got intra-abdominal varices that, need a procedure, that's a high-risk procedure. Like, we have to have discussions. We understand there can be really negative outcomes, but in looking at it and saying repeated admissions for encephalopathy with the opportunity to avoid that, having the discussion with our colleagues that have the expertise in doing it, I think those open discussions are what ultimately push care. It will push care for everyone, not just say at our center. And I think that's the important thing.
Very nice. Well said. I have one last question, and it's kind of for Tom. Is there ever a world where there will be enough livers to go around for everybody? Like in terms of work that they're doing with like stem cells and like in like creating a liver in a laboratory? If this is like something that I'm totally off my rocker and asking, or is this like a real possibility at some point? Like, do people like talk this in serious circles?
Absolutely. It's such a great question. And full disclosure, I do research with a company that's actually working on this. So it is very real, right? And I think it started with, about, I couldn't even tell you, but I want to say about 20 years ago in the United States with this idea of doing living donor liver transplant. So we weren't necessarily fully dependent on the deceased donor model, that we do many of these throughout the United States a year, variability across centers as far as volumes. Now, right, I was just at our big transplant conference a week or so ago out in Philadelphia, talking about perfusion devices, right? So taking organs from donors that have been donated and putting them on perfusion devices to sort of rehabilitate them. And what we're seeing at transplant centers across the country is that our ability to use organs that before were marginal is increasing exponentially. Then we take it a step further. There's been an incredible amount of work with like stem cells, things like that. One of our partners here at the University of Minnesota has NIH funding to look at literally growing human organs through stem cells and implanting them in sort of animal models as the first step to say, can we get to humans? Obviously, there's a lot out there right now as far as xenotransplant, right? So transplant of organs across animal types, where they have used, I want to say it was a pig heart and kidney that have been transplanted into humans that may have had reasons why they may not have been candidates for the traditional pathway of transplant. To get to the ultimate, cool stuff from my perspective is, right, the Twin Cities metro area in Minnesota is a huge biomedical hub. And with the undergrad university having very robust clinical sciences, there are companies that are working on growing and developing human organs then for transplant. And they are already getting to the point where they are literally growing human kidneys and livers in bioreactors with the ultimate goal that they'll be able to be transplanted into humans. So these aren't xenotransplants. It's truly human cells that populate the scaffold into functioning kidneys, functioning livers that will ultimately transplant, with their goal of, say, using cells from me, putting it into this liver, growing a liver so that if they're able to transplant it into me, I would never require immunosuppression. So this is very real time. This is stuff that's really, really happening. It is not science fiction. And I think just we are at a time where all of these things are just skyrocketing in frequency, in studies, and in practice.
Well, nothing would make me more excited to then have you on maybe in 10 years' time and you can talk about how now we're doing stem cell transplants in patients who are not requiring immunotherapy. Nothing's to put this service line out of business for interventional radiology. I don't think there would be hearts breaking across the country. That's very neat stuff. That wraps things up. We'll see you next time on the BackTable podcast. Siobhan, Tom, thank you so much for coming on.
Thank you.
Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dawn,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew
and Judy Dela Cruz.
Thanks again for listening.